All right, so in the next 20 minutes, I'm going to bring you all up to speed on what we consider to be the true burden of migraine from what we think about from a patient-centric perspective. Okay, there we go. Mouse works, guys. Okay, so these are my disclosures, which you can see. And again, in the next 20 minutes, we'll talk about how we identify the true burden of migraine. We'll talk about disability, both ictal disability and also how we identify interictal disability, and how we identify which patients may benefit from migraine prevention. So let's start with a case. This is a patient I saw. I'm going to talk to you about this patient when she came back in follow-up, but before I share with you her follow-up story, I want to bring you back to when I saw her in her initial consult, which was 6 months previously. She's a physician, she's 44 years old, and she has migraine. At that initial consult, she told me that she was having about 1 to 2 attacks of migraine per week. Each attack would last 1 to 2 days. They consisted of debilitating pain, photophobia, phonophobia, malaise. She also had a significant prodrome and postdrome. They were taking quite a bit out of her. She had a triptan. It was effective 70% of the time, and 30% of the time it did absolutely nothing. She told me that she was missing clinic about 1 day per month, and even when she wasn't missing clinic, she wasn't feeling at her best with most of her attacks. So within the headache community, we would talk about this in terms of absenteeism and presenteeism. So absenteeism are the days that she was missing work, and presenteeism is when she was at work but really not functioning at her best, and they were markers of disability. And she also went on to tell me that even on the days when she was not having a migraine attack, she was still thinking about migraine. And really this was the cloud that was over her head when she was thinking about commitments, went from a personal perspective or from a professional perspective as well. You know, we can say that she has cephalalgia phobia. Again, in migraine, we have a lot of interesting terminology that we use to communicate this with each other. Again, she's a physician, so she's really been around the block. She's tried a lot of medications before she's even come in to see me, and she told me that she's been on topiramate, she's been on antidepressant, in her case it was duloxetine, and she's been on a beta blocker as well. And she shared that these medications had either not worked or led to side effects, and at this point she was not taking anything. So we had a long conversation. I talked to her about migraine. I told her about the pathophysiology. We had a long conversation about migraine education, and ultimately decided that she would be a good candidate for one of our new migraine medications, specifically a monoclonal antibody. So I concluded the appointment by sending off the prescription. She had trouble obtaining it, but you know, being a busy physician, she just kind of gave up on herself, said forget it, but came back to see me 6 months later. So this is her follow-up. She told me that the education that we provided was actually therapeutic. In fact, I helped her cephalalgia phobia, and she is no longer having those 1 to 2 attacks per week that she described at the initial consult. And instead, she's only having about 1 attack per week, but as you might imagine, it was on her busiest clinic day, which was Wednesday. It was her resident clinic day, and that's when she was having her migraine attack. She's no longer missing clinic. Her triptan is more predictably helpful and reliable, but she went on to explain that, you know, I'm still not feeling quite at my best. My attacks are still unpredictable, and when they do happen, I'm not able to fully engage with my family and commit to my commitments. And her question to me at this appointment was, you know, that monoclonal antibody you prescribed for me, and I just, didn't follow through with it. Do you think it's still worth it for me to try that at this time, knowing what you know about me now 6 months later with my 1 attack per week that I'm having? And to really engage her in conversation and to make that decision, we need to know about updates in the literature. And we know a lot about migraine at this time. We know that from this a recent publication from about a year ago, and we know that while migraine prevalence seems to be relatively stable over the last 3 decades, what has changed is the burden of disease. In fact, our colleagues who published this work found that even though the prevalence has really not changed a whole lot, we are seeing higher burden associated with migraine, and this is manifested by missing work, school, and people attesting this having a greater impact on their relationships with their family and social functioning as well. And the authors went on to speak about why this might be, and they had a lot of potential explanations. Over the last 3 decades, we've changed the way we do clinical trials, so maybe this has to do with changes in study methodology. Our campaigns in terms of destigmatizing migraine, our migraine advocates and all the advocacy communities and societies have done a lot of great work in destigmatizing migraine so people are more willing to speak about it. Maybe that's had some great work. And even though the prevalence hasn't changed, maybe it's become more chronic, and that's leading to greater disability. There's changes in employment where women are working outside the home now. There's a lot of discussion on air quality. If you were at the last session, you just heard a great talk by Dr. Lipton on his research on opioids. So there's a lot of potential explanations here, and it could possibly be a combination of a lot of things as well. We also know that social determinants of health impact migraine chronification as well. So if someone's insurance status, their employment status, their education level, income level can all impact migraine chronification too. So it's multifactorial for sure. And additionally, there's a lot of data looking at people who have episodic migraine and what their lived experience looks like. In fact, this won the Wolf Award in 2021. This data identifying that people who have 8 days of migraine per month can have a similar lived experience as to someone who has chronic migraine. It really speaks to that interictal disability. And the Overcome study in 2022 demonstrated people have at least 1 migraine attack per week. Their lived experience can be similar to that of someone who has chronic migraine. So this goes right back to my patient I saw in clinic. And so I think what we can take from this, so any of us as a clinician in the audience, is really how we communicate this with their patients and how we speak to our patients about migraine. Really asking these open-ended questions, asking them about how does migraine impact your quality of life, and really asking questions about to really gauge the full spectrum of migraine in terms of this ask, tell, ask strategy as well, because sometimes we also know that while migraine is underdiagnosed, chronic migraine is even more underdiagnosed because people tend to minimize symptoms and ignore daily pain. So when I ask my patients, how does migraine affect your life? These are just stories that my patients have shared with me. They'll talk about how it's impacted their social connections with their friends, their ability to parent their children. A patient just last month told me that her husband left her because of migraine, and we also know that about 1 out of 5 women chooses to avoid pregnancy altogether because of her migraine diagnosis. So this goes, I think, to the interictal aspect of migraine, because nothing here is about the pain. It's about their connections and their communities, really what many of us, I think about in terms of what gives their life meaning. So when we talk about migraine-associated disability, there's a lot that we can speak about. We're all very familiar with the pain and associated symptoms that happen during an attack. Everything I've been speaking about to this point is that interictal disability, right? So what happens and how somebody feels when they're not having an attack in between those things. And all of this can be a target for treatment. We also just recently have data from the Overcome study speaking to stigma and how that can affect migraine burden and quality of life. And what I want to point out here is someone who has 4 to 7 monthly headache days, their experience here is not that unsimilar from someone who has chronic migraine. So again, it comes to that interictal disability. So we have recommendations from the American Headache Society that if someone has infrequent attacks, even as 2 to 3 days of migraine per month, but it is significantly disabling, and they do not have good, reliable acute treatment, that individual is a candidate for prevention. And for the clinicians here, I also want to remind everyone that it's really important on all of us to screen for chronic migraine as well, simply because our patients are those who often tend to minimize symptoms. So we can do this by asking just a couple of simple questions. So if we feel that our patient has migraine, ask about, how many days of headache do they have per month? And of course, our patients are typically not counting out the days, especially when they've never seen us before in that initial appointment. They didn't know that they need to do that. So I might simply ask, do you feel that you've got more headache days than not in a month? If they say yes, then they probably have chronic migraine. And we can even become more granular and simply ask how many days per week or days per month are you 100% completely, totally headache-free and do not take any medication at all. And that can also give us some really useful data as well. And this is additional data really emphasizing that taking into consideration the patient perspective on their diagnosis and what they want out of their treatment can really help with treatment adherence and treatment success. So this is why it's a really exciting time in headache medicine, because we have so many different options with so many different mechanisms of action and modes of administration, because it's definitely not a one-size-fits-all, and having so many different options be a first-line option really enhances that discussion that we can have with our patients. So I also want to point out that last year we published this research priorities from the American Headache Society. This is a huge undertaking that was really a patient-centric body of work. There are 25 different research priorities within 8 different categories published. It was an international stakeholder team that included researchers, clinicians, patient advocates, really everyone who's involved in this migraine space and has, cares about it from different vantage points, and really helps us to guide where the field should go as we look forward over the next decade. And I think it's something that we should all keep an eye on as new research comes out too. So, and then finally, a position statement was just published from the International Headache Society. I know Dr. Alani will be talking about this in more detail, so I'm just going to touch upon this. But as we think about what do our patients need, what do we want for our patients, I think we can really move the needle further by thinking about potentially even migraine freedom as a potential goal. So that's where I see the field. I really want to think about beyond pain and headache, think about total migraine freedom, and think about their total lived experience with this disease, even on the days that they're not having a migraine attack. So with that, these are our take-home points, and I'm going to move on to Dr. Alani. Thank you so much.